Good morning, everybody. Can everybody hear me?
I can hear you, Jennifer.
Okay, perfect. Happy Friday. We are going to wrap up our PFE series today with some implementation. So I have Katie Reese and Lori Galeotto with me, and it is Jennifer Sorensen with Compass CTN here in Iowa right now. Okay, so just to start off of an overview, we're going to recap. We're going to have a follow-up discussion with any lingering questions. We're going to show how to put information to use, talk about what's next, and then have our ending discussion. Whoops. All right, so I just want to start with this slide of what is person and family engagement. I love this slide. All of those wonderful words blended together in order to create this footprint, which is really what we're trying to do with healthcare, is put a footprint out there of person and family engagement and what that truly means to the communities, to the patients, to the physicians, and everyone else involved that benefits. The PFE focus areas that we have been touching on over the past couple of weeks have been health literacy and patient activation. We've shown you how to use the SOL SNE and the PAM along with the readiness ruler and provided you with resources as well. If anybody is in need of those and didn't get those, haven't been able to find them on Innovation or in healthcare communities, send us an email and we will ensure that those are out there again. I really like this slide, measuring the engagement to activation. Process and a destination. So this comes from the PAM tool and it goes through the different levels. I really wanted to put this on here as a takeaway because it's really good information and also for you to reference later. And go ahead, Miss Katie Reese.
All right, had to remind myself to unmute myself. So we've talked a lot about the tools that we've used and how to kind of actually use the tool themselves. But we wanted to talk a bit about, how do we actually use this in practice? When we're, on site or with our practices, they say, okay, so we practice, the SOL SNE tool. I know how to use it. I can flip through those charts. When and where do I use it? A lot of times we talk about this. People think that they need to be doing it with every single patient every time, and that is not correct. Just as we do, say, with our CAPs or with a lot of the other things that we do, kind of sample through that. So make sure to talk with them about sizing it and making it approachable for them. It's not an everyone or nothing type of approach we want to look at. So a lot of times one of the easy ways to kind of go through is if they look at a percentage of their patient population. In that, kind of that initial random sampling. It could be something that they pick a day of the week and say, right now we are so busy, but I think maybe we could start doing this with our patients on Fridays or Tuesdays. The other thing I always really encourage people, especially when we're going to talk about using it and getting the most impact of it right at that very local level, the biggest return on investment, is to pick a priority population and target them. That doesn't mean, say you're really working hard with your patients living with diabetes, that you have to do it with every single one of your diabetes patients. But pick a sampling size even within that. And one of my top examples that I used when I use the tool, but also when I work with practices, is to say your newly diagnosed diabetes patients. So we're going to start that with them. So then again, it starts them off at that first set. And I may use the health literacy tool and the readiness ruler as I go through. And actually, I would do that. So I'm going to play that in as part of my interaction with them. And then I'm going to go through and I'm going to use it a couple different times. The other key thing is to remember that these tools don't have to be used only by one person in that staff. We want to make sure as we look at kind of who our patients are that we're going to use the tools with, pick and prioritize who within your practice can help you do that. So there's a lot of value even at the registration desk and at the front desk or when they're closing out, having people to go through and they could do a health literacy assessment there. You could go through and talk about a couple of different things that are there. It could be your MA or your rooming staff that initiates even say that health literacy assessment, and then that way they have that assessment results, before the provider goes in to see them, then the provider is able to use that in their dialogue with that patient, and then also be able to follow up with any of those different cares afterwards. Nurses, of course, we know our nurses are having touch points with them, and our physicians are really important in this conversation. When we say we want to have our team do it, it doesn't mean that we don't want our physician to be involved in the process. So either they're administering it or they need to be using the information from that when they're dialogue with their patients and they're talking about treatment options and those follow-ups. Frequently, our health coaches, if our practices are fortunate to have a health coach or someone in that role, a care coordinator, a patient navigator, those are oftentimes the prime folks, especially when they start using these tools, to be the primary folks for it. They have a little bit more time with the patient to go through the tools and actually not only do the assessments, but then implement those when they're going through those shared care plans and things along that line. And another really cool opportunity, and Jennifer actually brought this up too, were some of the clinic volunteers. So we have different folks, especially if we have some hospitalists that are part of our network. I know our partner network is varied. But if there's a clinic volunteer that's in there that while patients are maybe waiting in the waiting room or as a follow-up, they can go through and they can do especially the health literacy assessment. You know, that's kind of a fun thing to kind of go through and do as long as they're trained. So that is one thing we want to make sure that we do is this isn't something that we just drop it in front of somebody and say, okay, try to figure out how to use this on your own. You're going to kind of go through it. Here's a really quick thing. Make sure people are well trained and how to have that conversation and to do it well, because that really plays into how engaged the patients are in that process and how they buy into that. So next slide. So where to use the tool. So here's a quick little map that kind of goes through a patient's journey. And I like to go through this because we say who's going to use or what that's going to look like. And this is just a sample. But when you think about with our practices and they try to play out where can we use this tool, where would we implement? I want them to sit down and think, okay, so what does the patient experience look like in the practice? Where are their touch points? Where does it make most sense to use this, not only for where they're going to be in our practice, the time that they'll be in each of those locations, and the staff that we have available to do that. I also encourage when we look through this process that we go through and we think about then where would I apply that information? So for example, a health literacy assessment, I'm not going to wait until payment and until they're leaving and getting their summary information to do their health literacy assessment, because I'd like to know that information earlier on in the visit. So that way we can apply it right here, then and now. We don't have to wait until the next time they come in to make use of that. So even as we kind of go through the patient's journey and we think about person and family engagement, registration at the specialist and outpatient clinic, we're looking at that. They're there, they're filling out forms, or they're sitting in the waiting room in the lobby. Good. Again, we can use our tools that are there. The other thing I encourage is that I know we're focused on our primary tools for health literacy and patient activation, but let's not forget about engagement and the environment that plays into that. So in our clinic, in our lobbies, it's a really good opportunity for us to go through and even maybe have, with our Choosing Wisely, we've got those 5 questions to ask your provider. Giving them something that's meaningful beyond People magazine to read while they're in the lobby is really helpful because it helps prepare them not only for their visit, but then also for that engagement and that interaction. So doing that in the lobby, having those posters and that imagery and the brochures and things like that in the lobby, in the patient room when they're kind of going through different things. So we have that pretty artwork, but sometimes maybe we have another pretty description on the types of things like be ready for this, be ready to ask the doctor questions, share this information. We have a lot of those different things that are there, so let's not forget to include these components. From that point, we go in and before we get to the doctor consultation, one of our medical assistants rooms them. So a health literacy assessment, you could implement that there. The MA could go through, do the health literacy assessment, and then before the consultation with the provider, then they're able to go through and say, okay, this patient scored this amount on that, so we might want to make sure that we're looking at those things. Following that procedure, when they go through, they might have some testing, such as a blood test or x-ray or any of those different things. Again, those are different components within our practices that even if they're not actively doing the assessment, they're not the primary owner of that process, they can reinforce that through equipping them to how to have those conversations, the active listening, teach back, different pieces like that that really play in to that engagement experience. The one thing I really like about this patient's journey is it includes the registration at the pharmacy. So it includes that pharmacy aspect. And I think especially when we talk about health literacy or we talk about patient activation, our pharmacists can do a lot with that information to extend the impact of knowing that information beyond just our in-clinic practice. And that's going to feed back to their follow-up, how they care for themselves when they're out in the field, and things along that line. So again, when we look at this, where to use the tools, I think it's really important to sit down with our practices and say, okay, what are the patients we're going to use them with? What does their journey look like, and where can we fit this in? So, and looking at those two tools, but then also the overall patient experience that we're supporting them throughout that. So just a couple quick, kind of highlights and reminders that we have in there. So on to
Katie,
Lori,
thank you. I love that slide. It's such a great visual to share with others. All right, Lori. I'm going to move on to some general patient population information. I remind you, Lori, to take yourself off mute. Lori, we can't hear you.
Okay, let me try again here. Can you hear me now?
We got you. Yep.
Perfect. All right. So good morning, everybody. So I just wanted to run through a few slides here where I wanted to give some examples of interventions that we can use to improve or work with our patients on health literacy and patient activation. And Katie touched on some of these, and actually the interventions will overlap between patient activation and health literacy. I've divided them up a little bit because both tools can be used either with the surveys that go out to patients, so that the information that they get back regarding these two metrics is really general population information. And then you'll see other slides that target more the individual patient. So if you're working and doing the tools with an individual patient, how you can plan your intervention. So the first one here, we have the health literacy. This is if you just understand what the health literacy of your general population is and what the practice can do as a whole to address these. So obviously, the educational materials that you have, there's the rule of thumb that you print those at a 5th grade level, but if you tend to have lower health literacy in your practice, you probably want to go more for pictures or something much easier to understand. And because we know that the patients with limited health literacy, they're less likely to use preventative services, they have more difficulty understanding instructions, directions on prescription bottles, following up, they have more trouble with going to specialists and getting that information back and understanding what to do with it. We want to make sure that the practice has processes in place where they can really proactively address gaps in care. Look for those patients who haven't been in for their preventative screening, their immunizations, they're reaching out to them. They want to have processes in place for care coordination, so not just closing the referral loop, but actually have a person who can help walk patients through their transitions of care. Maybe the Ask Me 3. The Ask Me 3 is really coaches a patient when they go into the room to ask their provider, what is my main problem? What do I need to do? And why is it important for me to do this? And then, of course, like Katie talked about, really utilizing the pharmacist, having processes in place for medication management, and just really supporting those patients in their self-management. Next slide, please. And then if you're working with the individual patient, hold on here. Sorry, I'm looking ahead. So for health literacy, when there's any change in treatment plan, if the doctor can communicate that to his staff, then somebody can reach out the next day after the patient goes home and tries to make those changes and be able to make sure that the patient, once they're in their home, understands what they need to do. We can use really simple action plans, just telling the patient, so if they have heart failure, to weigh themselves every day, and if their weight reaches a certain number, to call back into the office, just to make it very simple for them. With a patient with higher health literacy, they may be able to adjust their diuretics or make some medication changes to help manage their disease at home. But if they have lower health literacy, then we just want to make it as simple for them to know when to reach out to their health provider. Teach back, So when we're working with the patients, we want to make sure that they're able to tell us what we've taught them to make sure that they're understanding. And then medication management again. So a patient with low health literacy, work with your pharmacist, have them help review those medications. If it's really difficult to get those medications set up, maybe the pharmacy can put blister packs together, just make everything as simple as possible. And then you can use also the information you know about the health literacy of this patient to allocate your resources. So obviously, patients with low health literacy, you're going to need to have the health coach with them, or you're going to be needing to spend more time with them. Next slide, please. So then we go to patient activation, and honestly, a lot of the same interventions that you use for health literacy, you can use for patient activation. But if you have a practice maybe who has the PAM tool integrated into their survey, and you're just getting practice level information about general patient activation, there are some things you can do on practice level. For instance, making sure that you have shared decision-making tools available, and maybe you can have printed materials, but they also have videos too that might be easier for a patient to watch, or maybe they need both. The practices can host peer-led self-management groups. A lot of times those are available, they just need a place to really host them. Those can be maybe 6-week programs where you bring in patients with chronic diseases to work with a peer leader. They have them for diabetic management as well. Encourage goal setting, using the readiness ruler just in general with patients, and then you want to have multiple avenues for the patient to contact the provider. So that could be through email, through portal, through texting. Again, you want to make it as easy as possible for these patients to get their questions answered. Next slide, please. Okay, and then when you're working with the individual patient, of course, a patient with low patient activation does a great job with the health coach, where you have the motivational interviewing and really targeting what's important to the patient and what's going to motivate them to take better care of themselves. If you have those peer-led self-management groups in place, then you can choose to refer your patients there. When the patient's coming in for a doctor visit, it's great if the health coach can call, or a staff member can call the patient before, kind of coach them, make sure they have all their medications ready to go. If they have questions, make sure they write them down. And then when you have the patient in the office, it's best to address multiple needs in one visit. So if you have a diabetic who's not great about showing up for their appointments, but they come in for bronchitis, you got to grab them when you have them and do their foot exam, their A1C, any lab work that won't be affected by, their illness that they have at the time. So those are just some examples of what to do with the information that you get back from the tools that we're using. And then I did want to make, when we talk about, next slide please, Jen. So when we talk about measuring success, of course, there's lots of ways to measure success, but we're going to look at the PFE here that's coming to the OPAT soon, and wanted to let you know what that's going to look like. So the metric responses for each metric, we're going to have yes, implementing, planning to implement, or no, not implementing or planning to implement. So there's going to be a pacing event on Tuesday, May 1st to really talk about what that's going to look like. And then the metrics are going live on May 2nd. And Katie, you might be able to speak more to that if need be.
Yes.
Maybe that's enough.
Yeah. Thanks, Lori. I think the main thing for this is that the only change with this, and the biggest part when we talk about measurement and implementation, is to make sure that we're working with our practices to check the box. Because we have actually implemented our PFE metrics as part of our PAT a while ago. And so this has been in process for a long time with CMS. And so Really, this changes the metrics in no way. So again, those same three results that were used to saying, yes, we're implementing, we're planning to implement within 6 months, or no, we're not implementing or planning to implement, are all be on there. So again, I'd encourage everyone to look at the pacing event on Tuesday, May 1st, because the other thing with the OPAT is that they're also going to be doing bulk uploads. So there's some other functionality that they're going to kind of go through with that. So I encourage everybody to be on there. And those are supposed to be live on Wednesday, May 2nd. So just make sure that you're working with your folks and you're aware of that, and that we're making sure to follow up with them in a prompt manner to make sure to capture the work that they're doing. So, and I think the cool thing is, again, that planning to implement really allows us, as we know, we're targeting health literacy and patient activation because those were our lowest responses. And so that planning to implement allows us to capture them as we're working with them. So they don't have to wait to go from no to yes until they've got everything in place. They can do that planning when it really helps them to feel and capture what they're accomplishing in process.
Thank you. All right, so we're about at wrap-up time, discussion time, as I want to call it. So let's talk a little bit more about what you guys are all seeing out there, bring anything to the table to discuss with everyone on the call.
So as we wait for folks to kind of pop up, Jennifer, I'm going to pose a question for us to kind of discuss just because I'd like to hear from our other folks on the line. So when we talk about implementation and measurement, we talk about, that initial thing, kind of that process measuring whether or not we're even doing the quote unquote metrics. But for you guys, what are some of those other things that maybe even from some of your folks that are doing some of these other PFE things, because we all have practices that are doing them. It's just not widespread among our network. What are some of the other ways that they're measuring, or some of the successes that they've seen that kind of reinforce them to keep the process going? I know a lot of folks reference back and after a period of time, especially with patient activation and things like that, that even within satisfaction, so what their CAP scores, they start to see a lot of changes in through that. They also start to see, especially with folks following up with their visits, we kind of talked about that with engagement. So as they kind of go through part of that activation, so they're following back, they're feeling more comfortable when they're at home. Eventually, we know our outcomes, more engaged patients lead to more engaged outcomes, but I'm wondering if any of our other partners have heard or seen that, or even had discussions with their practices. Silence, come on, guys. So is that something that we haven't discussed with them yet? Is that something, because I'm thinking too that if we have some silence, it may be something that we're not as comfortable talking about it, or we're not at that point yet. So I mean, that's perfectly fine if we're not there. There's no wrong answer, but that helps us to know kind of as we look ahead towards our 90-day goals, how we can best support each other to meet those goals.
Katie, this is Joyce. Can you hear me?
I can. Joyce, how are you?
So you know me, I'm not shy. So I think some of the work that we're doing around patient and family engagement, I think we've got some really good examples. I just don't think we're ready to actually report upon them. We do, like in our quarterly report, we kind of highlighted a few of the work that's being done, but I'm going to kind of call out Cleo because she's working with the PFE group in Augusta University. They've had a very strong PFE movement since the 90s with their inpatient side. And now working with Julie Moretz, they're really trying to pull it over into the outpatient arena, and really trying to get their hands around how will this best work in the physician setting. And I don't know if Cleo, or Tyra, because they're developing a actual plan, but that hasn't been really approved yet. But it's getting there. I mean, it's just I think we're still in the early stages in this outpatient arena. And Tyra, I don't know.
Cleo, are you on?
Tyra, you have to unmute yourself. No. I can hear you because you're in the office next to me, but we can't hear you online. Go ahead, Tyra. Nope.
Well, I have a quick question while we wait for Tyra. Joy, so when you guys go through and you talk about you're trying to capture, but you're not ready to report yet, are you talking about are you guys even capturing on their PFE metrics that they're, like they're planning to implement on there? Are you capturing that middle ground, or are you talking about reporting such as in like an emerging stories, like full template?
Oh, Tyra just was an emerging story. So here, Tyra, go ahead.
Yeah, so in regards to what we're doing with One Practice, we're just helping them come up with, I guess, like a 90-day to 6-month plan. And we're focusing on, it's on the computer. And we're focusing on a lot of shared decision-making and teach back. And if we just focus on those, and we're just going to pick, we haven't really selected the demographics yet, but we are saying, I think you mentioned earlier, we are suggesting that they do either their newly diagnosed diabetes patients or the ones who are at risk for getting diabetes. And we're just asking that they do it in One Practice first as a pilot and then spread it from there. So that's just one of the PFE plans, the biggest one we have so far coming up. So we'll see how that goes.
But to answer your questions, no, we're considering like what of the 6 measures the quality improvement advisories are asking along the lines of what they're doing. And when we look at what they're saying they're doing, it's the validation piece. Health literacy is probably the one that, yeah,
that's the one we don't have much traction on. So I guess that's something we'll have to work on in the future.
Yeah, and I think you guys are really well poised, because the reason why I call out that SOL S&E form is, again, it is a validated tool. I mean, it's built up, it comes in through AHRQ. That's who funded the work that went through with it. And then I think the really cool thing with that is, again, because we actually have some hands-on experience with that says, okay, no, the people who were administering, they found it was simple, it fit in the workflow, it supported them in the work that they were doing. And especially if they're working on with that teach back and that shared decision making, that health literacy assessment really fits in well with that. So it can be something, we want them to be using teach back in all avenues. But when I do a teach back education, and Joyce, you'll probably remember this even when I did that with the hospital association down there in Georgia, we talked about health literacy. And so for me to even go through in that follow up on that teach back and different things like that, I would often do that. So between a teach back and, actually working on the plan, like a shared decision making, okay, here's our treatment plan, I would do some of that health literacy assessment. And especially if they're going to work on like kind of those, patients at risk for diabetes or those newly diagnosed. And even they don't have to, so say they're working on the bigger strategy and they're going to use teach back, always use teach back, and they're always going to do shared decision making. The health literacy aspect of that, do it within a smaller population, test it out within a smaller group, even of that subset. So it doesn't have to be, again, even if you're integrating it and weaving it in, you can even target within those groups and make it approachable. So start with, 20. Mm-hmm. They have a goal to do, with 20 folks within that period of time, and to kind of go through that. So, or if there's, okay, I know this person, when they were newly diagnosed diabetic, they are very far down on the scale. It's going to be very complex. It's going to be very arduous to get them into control. They were diagnosed very late in the game. Those are the folks I'm going to do a health literacy assessment on too, because we know they've got limited time. And so you have to prioritize some of those different things. So I think you might even have a conversation like that with them and just see it where they're at. They might be more ready for it than we think.
Okay, thank you. Appreciate it.
How about anybody else? Anybody else besides Georgia brave enough to speak up?
It's Jennifer. I think something that we touch on here in Iowa is that it just is so natural for patient and family engagement to be a part of the workflow. And so because it's so natural, practices forget to mention that it's actually happening. So I think really touching on what Katie said about having those conversations and really encouraging your practices to talk about it and to be excited about it, because what they're doing is, from a national perspective, extraordinary. So just really highlighting on that, just to piggyback off of what Katie said. You know, I have a really, really small clinic in Iowa, only 6, I think there's only 6 doctors at it. And I think I talk about this clinic way more often than any other clinic. But, you know, I think their quality person that came and talked at our learning community said it best when she said, I didn't know we were doing anything special. This is just what we've always done. So just really, you know, praising them for the work that they're doing, and finding out and having that conversation is just so key. So thank you, everybody.
Yeah, and the one thing for that small 6-physician practice in a rural Iowa community that Jennifer's talking about, that again said, this was just what we do. I didn't think it was anything special. I didn't know. It was called Person and Family Engagement. They were one of the 12 that were recognized by CMS for their emerging story. So again, we want to make sure that when we talk about this, the goal isn't that, you know, CMS gives us this big recognition, or it's this big formalized campaign or emerging story. The point is that we want these things to be, we want it to be something that it becomes so natural that they don't think about it, that they don't think that it's anything exceptional and through that. And so that's why it's more important to focus on those pieces. And then we can pull from that and have them get into the action of doing it. And then that's where our job as, you know, Compass PT and as the, you know, the QAAs, to identify and say that that's something extremely special and to call that through. So don't let you know, the emerging story or those different types of things sway you, but let's, you know, we can kind of get down to those brass tacks for it. So.
Great. So does anybody else have any stories they want to share? I just love hearing everybody's input and the work that you all are doing. All right, so I just want to thank everybody. We really had a good time, you know, putting these slides together and the interaction that we've had with everybody. And we really want to use these as discussions. And so any input, any stories, any resources regarding patient and family engagement that you want to share with us, we want to feature that in our newsletters, in the Compass Connect that they just launched, even if it ties into risk stratification and patient population health management with Lori. Please let us know so we can really be highlighting this stuff, because there's so many great things that everybody is doing. So just keep up the good work. Enjoy your Friday. It is beautiful here in Iowa. I hope it's beautiful everywhere else. And we'll catch you guys a little later. Thank you.